Hello, and welcome to One World, One Health, where we talk to people working to solve some of the biggest problems facing our world. I'm Maggie Fox. This podcast is brought to you by the One Health Trust, with bite-sized insights into ways to help address challenges such as infectious diseases, climate change, and pollution. A One Health approach recognizes that everything on this planet, the animals, plants and people, and the climate and environment, are all linked. One perfect example of these links is the problem of antimicrobial resistance, or AMR. This happens when bacteria, viruses, or fungi that infect people develop the ability to withstand the treatments that we have developed for them. This drug resistance can mean an infection that was once cured with a shot or a couple of pills is now much more difficult to fix. Sometimes infections become completely impossible to cure. Drug-resistant infections directly kill more than 1 million people every year, and they help kill about 5 million people a year. It's such a big problem that the United Nations and other major organizations have focused on it throughout 2024. To help set the stage for these international discussions, the Lancet Medical Journal commissioned a series of papers led in part by the One Health Trust. Aislinn Cook of St. George's University in London and the Health Economics Research Centre at the University of Oxford helped put together one of these papers. It proposes some targets that can be used to plan out the fight against these drug-resistant infections and to measure progress. She's joining us today to talk about these targets. Aislinn, thanks so much for joining us.
Thank you for having me, Maggie.
Aislinn, you propose some targets for reducing these growing rates of drug resistance. Can you tell us why targets like this are useful?
Yeah, so targets, as we kind of talk about in the paper, there was a UN General Assembly meeting in 2015, 2016 that kind of started to talk about needing to address this. And obviously a lot of that came kind of without targets. We have one target currently that's 60% of antibiotic use should be access. And thinking about targets, it's kind of a way to bring political will, accountability, and funding. So by aiming for something, you can hope that countries and, UN bodies start to get behind kind of, we need to fund this to actually measure this and start to kind of make a difference. They also allow you to see how well you've progressed. Ideally, we are actually reducing rates of drug resistance or reducing antibiotic use. So we need to know kind of what we're aiming for. And hopefully we can update the targets as we improve.
Who are the targets for?
So right now, the targets are kind of aimed at the UN level and at the kind of country level, and thinking about global, kind of getting some global will behind needing to actually address this problem. We've talked about targets related to reducing AMR mortality, reducing inappropriate antibiotic use in humans, as well as actually reducing inappropriate antibiotic use in the animal sector as well. So it's aimed at people, not just healthcare professionals, not just microbiologists, but looking at kind of the whole One Health sphere, as well as trying to get global action behind this in that way.
Can you tell us about the targets that you do propose?
Yep. So we proposed 3 targets termed the 10, 20, 30 by 2030. The first one being aiming for a 10% reduction in mortality from AMR. The second being a 20% reduction in inappropriate human antibiotic use. And the third being a 30% reduction in animal antibiotic use, and aiming to do this by 2030. With thinking about reducing antibiotic use in particular, which 2 of these targets aim to look at, we've been very specific to talk about reducing inappropriate use. We don't want patients and animals who actually need treatment to not have access to that treatment. So the big thing here is we know that patients, both animals are prescribed, and we use antibiotics in animals somewhat inappropriately. And we know that humans are probably prescribed antibiotics that they don't necessarily need, particularly in this case in primary care. Coughs and other things. So the aim is to actually use the tools that we have and the clinical guidelines that we have a bit better to start to reduce inappropriate antibiotic use. The other way that we can do this, and this also leads into the 10% reduction in mortality in AMR, is to use other tools that aren't just around prescribing patterns, but to start to use things like vaccines that cover lots of different illnesses. So viral vaccines, bacterial vaccines, such as your pneumonia vaccine, your rotavirus, things that reduce symptoms and mortality that might lead to prescribing, but also might lead to severe outcomes, as well as improve things like sanitation and infection prevention and control. Obviously, the biggest thing is that if you don't get an infection, you don't get an antibiotic, and you also can't die from a resistant infection. So we are really looking to kind of make sure that this is safe for people, while we also aim for reducing the impact of these infections and taking action towards reducing AMR.
Why such seemingly modest goals? A 10% reduction in mortality, a 20% reduction in inappropriate use, and a 38% reduction in inappropriate animal use. Why not just go for the whole thing and abolish all drug resistance?
I think it's a bit more complicated than that. I think you've had a lot of different people on here talking about how we get drug resistance. And antibiotics are a piece of that. We know that overuse of antibiotics drives drug resistance, but we also know that all these bugs mixing in the environment and the way that effluent comes in wastewater are other things that drive drug resistance. We also know that, we're going to do our best to bring drug resistance down, but bugs have been evolving like this for centuries. The reason we aim for targets like this is that they are actually achievable. I think there is a risk of, if you set right now, we're kind of at stage 0. If you look at some climate change is a lot of what we talk about as kind of a parallel type of area where it's a complicated problem with lots of stakeholders. And climate change has been trying to set targets and setting targets for, 40 years. And we're just kind of getting started if we're on our second UN Assembly meeting about AMR. So trying to set targets that are achievable by 2030 so that you can also get funding and will behind these. If we set two unrealistic targets, then it's really hard to get the buy-in to actually start to make progress towards them.
And of course, these are overall targets, and some countries or regions might find them easier to achieve than others. So I would imagine some countries can do better, and some countries might need to set a more modest target.
Yep, exactly. So these are, as you said, overall targets that we're really aiming for. But as you can see through this paper, and we talk about this a little bit, is that current pattern, particularly around antibiotic use, current patterns of antibiotic use and the rest of public health and health system in different countries are at different levels. So in a country that has a really well-functioning health system with lots of infection prevention and control, good rollout of vaccines, these targets might be really achievable, as well as countries that have low mortality from infections. If you are looking at countries that are grappling with really complicated health systems problems, then it might be a bit more difficult to achieve some of these targets because you're trying to roll out infection prevention, you've got to improve sanitation and roll out vaccines. The other thing that really think a lot about is when we talk about reducing inappropriate use, it's very important that it is actually in patients who don't need treatment. We don't want any patients to go without treatment that they do need. And I think that's where targets and within countries, and we talk about this a lot in the paper around kind of optimal targets for countries to derive, and that actually deriving a fair share of antibiotics. So some countries you can see, we kind of show that it's a bit unequal right now. The total use of antibiotics in different countries, in high-income countries in Europe, is a lot higher than countries in Africa and Asia and low-income countries that might actually need more antibiotics. They might not be using enough right now to treat their burden. And so we spend some time in this paper working through some methodologies to try to think about benchmarking what expected antibiotic use should be for countries based on their disease burden. It's definitely expected that some countries should be using more antibiotics than they might currently be using because they don't have enough to treat their population. And it's also, we know that some countries are using way too many antibiotics. So what we are trying to really focus on is improving access to essential antibiotics. So access to these aware category access antibiotics. So the WHO has classified all the antibiotics into what's called the aware system, which stands for access, watch, and reserve. And within this, they've classified all the antibiotics. I think there's about 250 on this list. And they've also then honed in on about 40 that are on the essential medicines list. And using those, in 2022, they published the WHO Aware Antibiotic Book, which provides risk-based prescribing guidance for the most common infections in primary care and in the hospital setting. And using guidelines like this, where it's taking a risk-based approach, is really important. So there are patients that are at higher risk of outcomes or present with more severe infections, and those should definitely be prescribed an antibiotic. Aware Book recommends access antibiotics for most primary care infections. It can be about 80 to 90% of those infections can be access antibiotics, which are our narrower spectrum, more affordable, potentially safer antibiotics. Whereas right now we know that actually in the primary care setting, there's a lot of overprescribing and potentially inappropriate use of watch antibiotics, which are kind of broader spectrum with higher potentials for selection of resistance. And so there's a really kind of easy, I say easy with there's a lot of health system stuff underlying that way to think about reducing inappropriate use, which is reducing overprescribing of watch antibiotics in the primary care setting. It's still not saying that patients aren't going to get any antibiotics, and we're not tackling, really severe infections in hospitals. Patients like that should still get treatment, but making sure that everybody still gets the antibiotics that they need without using too many of them, because it's a finite resource for the whole population.
So in other words, it's like saying, go ahead and use amoxicillin when you can, save the vancomycin for when you really need it.
Exactly. It's saying that actually amoxicillin in primary care is really still quite effective everywhere. And right now we know that there's not enough amoxicillin, there's not enough access antibiotics being used, particularly in some countries. There's reported stockouts. I think there's what we say access to access antibiotics is kind of a big part of aiming for appropriate use of antibiotics, is making sure that if you need an antibiotic, you have one and you have a right one that's at the right dose. It's of good quality and it's affordable, while not using kind of potentially more expensive antibiotics that really you don't need, and especially if you don't even need an antibiotic at all.
Who enforces targets like these? Does anyone? And if so, how would it be enforced?
So I am not a legislator, I'm a researcher, but this would be kind of part of a global. So firstly, we've proposed in this paper that we need an independent panel. We need an independent panel to synthesize the scientific advice, drive forward some of the kind of questions. And it's an independent panel for both access for antibiotics. And this would be a global process. I think really it's a UN process, and it's up to countries, I think at a certain extent, to think about what their levels of ambition are and to start to derive what their own policies are going to be to meet some of these targets and what is achievable. And that's where we talk through here different levels of expected antibiotic use that might be needed for country burden. But we're at the very beginning, I think, a little bit of this. So independent panel and then on to the wider policy process.
Can you give us some 4 instances of what a country might do to, say, reduce the inappropriate use of antibiotics in people?
Yeah. So we know that about 90% of a country's antibiotic use happens in the primary care or community setting. It's not hospitals where people are really, really sick. And that a lot of that use might actually be what we've been saying inappropriate. So most patients, acute respiratory tract infections is a really obvious example. So there's a lot of respiratory tract infections are viral. You won't benefit from an antibiotic, and a lot of them are kind of self-resolving. And the Aware book has a section on, I think, 6 different respiratory tract infections that are really common in primary care. And actually for most of them, it recommends no antibiotic treatment at all in low-risk patients. And we know right now, and we've seen studies coming out of lots of different countries, including, I'm based in the UK, but across Europe, there's a lot of patients getting antibiotics for respiratory tract infections. So an obvious starting place would be kind of mild respiratory tract infections, and not prescribing any antibiotics is one way that you could totally reduce inappropriate use. But inappropriate use could also be not prescribing watch antibiotics for a respiratory tract infection, actually shifting to prescribing access antibiotics, which are the first line treatment. We know that where patients are prescribed antibiotics, they are also prescribed more watch antibiotics for respiratory tract infections. So even just shifting from watch to access would potentially improve appropriate use of antibiotics.
We've been telling physicians and patients for years, stop, you don't need these. So your guidelines make it easier to come up with ways to better educate both the medical profession and the public.
Yeah. So like you kind of mentioned, there's kind of, as you said, demand side is the patients. So educating patients a bit better that when they need an antibiotic and when they don't need an antibiotic, and when they could use other kind of supportive care like ibuprofen, Tylenol, fever reducing meds. And then the supply side where prescribers need to improve their prescribing. This is obviously easier. I use the word prescriber. I'm based in the UK. We know that we have to go to the GP to be able to get access to an antibiotic. In a lot of countries, particularly in low and middle income countries, you can get antibiotics in a lot of informal settings. There isn't as much of a gatekeeper. So the interventions in those settings are going to be a bit more complicated and multifaceted. We can do prescribing guidelines where you have an official trained prescriber, a formal facility that will help improve things. But there's also this other area around antibiotic dispensing without a prescription. And so that becomes a regulation and a financial thinking about what those incentives are, and also figuring out why patients go to those more informal settings before they go to a GP clinic or anything like that. So there's a lot of really great work happening in the kind of sociology and anthropological space, also trying to figure out what the best interventions, behavior change-wise, would be for both supply and demand side interventions.
Aislinn, thank you so much for joining us.
Thank you very much, Maggie, for having me. It's great to be involved in all this work, a really exciting direction of travel for this.
Listeners, if you enjoyed this podcast, please share it. You can learn more about this podcast and other important topics at onehealthtrust.org. And let us know what else you'd like to hear about at OWOH@onehealthtrust.org. Thanks for joining us.
Thank you for listening to One World, One Health, brought to you by the One Health Trust. I'm Ramanan Lakshminarayan, founder and president of the One Health Trust. You can subscribe to One World, One Health on Spotify, Apple Podcasts, or wherever you listen to podcasts. Follow us on social media at One Health Trust, one word, for updates on One World, One Health and the latest in research on One Health issues like drug resistance, disease spillovers, and the social determinants of health. Finally, please do consider donating to the One Health Trust to support this podcast and other initiatives and research that help us promote health and well-being worldwide. Until next time.